Let's go over the warm-up review. First question, what's the mechanism of action of fomepizole? Fomepizole inhibits the enzyme alcohol dehydrogenase. Next, what effects will a non-competitive antagonist have on an enzyme's Vmax and Km? A competitive antagonist does not affect Vmax, which is the orange line here. The yellow line is the uninhibited enzyme. If you give enough substrate, you can still achieve that same maximum velocity and overcome the competitive inhibitor. The curve is shifted to the right, but the Vmax does not change. But this question is asking about a non-competitive inhibitor, which is the purple line. With a non-competitive inhibitor, you can't overcome the inhibition by giving more substrate. So eventually you saturate the available enzyme and you hit zero order velocity. What you'll find is that when you reach that plateau, the Vmax is lower. So to answer the question, with a non-competitive inhibitor, the Vmax is lower. So it's going to decrease Vmax, but it does not change Km. The last question, which G protein class does each of the following receptors stimulate? Alpha 1 is GQ, alpha 2 is GI, beta 1 is GS, beta 2 is GS, muscarinic M1 receptors is GQ, M2 receptors is GI, M3 receptors is GQ, and dopamine D2 receptor is GI. That wasn't so terrible, was it? Let's move on to the lecture.
Come one, come all, come out and see our video on ECGs. For one low price, it can all be yours. Guaranteed to raise your scores. We've got tracings, we've got leads. Count them all. 1, 2, 3. But that's not all. Call now and get AVL, RF. Act now, avoid humiliation. You gotta know axis deviation. PR intervals, QR complexes, deflection, infarctions. Great for both sexes. We've got EKG paper. Who could want more? Multiply those tiny boxes by 0.04. Without this ECG video, your patients may die. 10% off for a limited time.
All right, guys, so today we're talking about ECGs, the electrocardiogram. So ECGs, or I'm an old person, I might slip and say EKGs on occasion. Basically, ECGs are measuring the electrical signals as that electrical signal is moving through the heart. And there's actually a direction to that signal. That signal starts out at that SA node and then travels down the AV node and then the bundle of His and then down into the ventricles. So you can imagine the overall direction of that electrical signal is actually just kind of down and to the left. And the ECG, with all of its leads, is trying to determine if that electrical signal is normal or abnormal. So there are multiple electrodes that we place all over the body, which will measure that electrical activity through the heart. Now, you will often hear the term lead used when talking about ECGs, and a lead can actually have two different meanings. Now, sometimes the actual electrical cable itself is referred to as a lead, but I don't really want you to use the term lead in this way. A lead, when we use it in referring to ECGs, is the tracing of the voltage differences between two of the electrodes, and this is what you'll see on the ECG paper. Now, for example, lead 1 is the voltage between the right arm electrode and the left arm electrode. Now, how many leads are on an ECG? Well, on a good ECG, you're going to find 12 leads. Now, what are the 12 leads on an ECG? Well, it's leads 1, 2, 3, and then you have AVL, AVR, and AVF, and then you have V1 through V6, so V1, V2, V2, V3, all the way up to V6, which are called the precordial leads. Now, the first thing to realize, again, is that each of these leads has a specific direction. So let's look at this diagram of these 6 limb leads. Now here we see in which direction each of these leads measures the electrical activity. So your AVR is measuring the signal in the direction of the center of your chest from your heart to your right arm, which is why it's called AVR. The R is for right. AVF is measuring from the heart down to your feet. AVL is measuring from your heart to the left side. Now 1 is measuring straight across from right to left. 2 is measuring from the right arm to the left leg, and then 3 is measuring from the left arm to the left leg. So as you can see, each of these have a very distinct direction. Now, if you combine all of these leads together, then you might see something like this. Lead 1 is at 0 degrees, 2 is at 60 degrees, AVF is at 90, 3 is at 120, AVR is at negative 150, and then AVL is at negative 30. Now, this is definitely something that you're going to want to memorize. Okay, so now that we've established that each lead has a direction, how does that help us? Well, as we said before, as your heart beats, it's producing an electrical signal. It starts off at the top of your heart at the SA node and the atria, and then down to the AV node, and then through the interventricular septum, and then finally moves through the ventricles. Now, all of this is designed to produce a coordinated heart contraction. So there is a direction to this electrical signal, and a normal heart will have a net electrical signal that moves down and to the left. But this net electrical signal will be interpreted differently depending on which lead you look at. Now, if the heart electrical signal is moving in the same direction of the lead, then you will see a positive deflection on the ECG. Now, what does a positive deflection look like? So a positive deflection means that you'll see more of the QRS above the line than below the line. Conversely, if the signal is moving away or in the opposite direction as the lead, then the ECG will show a negative deflection, meaning that you would see the QRS below the line. Now let's look at an example. What would a normal electrical signal look like on AVR? So AVR is measuring the signal from the center to the right side. Now if the normal net electrical signal of your heart is going down and to the left, then you're going to have a negative deflection of your QRS complex because it's going to end up being in the opposite direction of that vector of AVR. So a net electrical signal going in the opposite direction of what is being measured means your QRS complex is going where? Below the line. Now AVF would be just the opposite. Since that electrical signal of the heart is moving generally towards the same direction as AVF, down, then you would see a positive deflection or a very tall QRS segment on that EKG. So AVR, AVL, AVF are called the unipolar leads. Now let's review the direction of the bipolar leads again. So your bipolar limb leads are 1, 2, and 3. Remember, limb lead 1 measures from the right arm to the left arm. Limb lead 2 measures from the right arm down to the foot. And then the limb lead 3 is measuring from the left arm down to the foot. And again, if we look at a normal ECG, leads 1 and 2 are usually going to have a positive deflection because they are measuring both left and down. Lead 3 can also be positive because it's pointing down, but on some patients this might be a bit more neutral. Now let's look at how to determine a normal or abnormal axis. This is how we're going to use all this information for some sort of practical purpose. So we're using our axis here, and the green section is the normal electrical axis. Now a normal axis is a net electrical signal somewhere between -30 and +90. Now as we said before, down and to the left. So let's go through a normal example here. So normally a person will have a positive deflection of your QRS on limb lead 1. Now there is more of that QRS complex above the line than there is below the line. Now that tells you that the net electrical signal is somewhere on that right-hand side of the axis, somewhere between -90 and +90 on the right-hand side in the same vector direction as that limb lead 1. We also generally see a positive QRS in lead 2. So we can then say that the net electrical signal of the heart is somewhere between +150 and -30. Now, if you have a positive deflection of the QRS in lead 1 and a positive deflection in QRS in that limb lead 2, then you can actually combine those two images together, and that gives you the net electrical signal somewhere in the shaded region that is common to both of these two vectors. Now, why is that important? What does this axis tell us? Well, if the heart signal is not going down and to the left into that section there, then that indicates some level of pathology. And when we're looking at the axis and we see the signal moving away from down on the left, then we call it either a right axis deviation or a left axis deviation. Left axis deviation is generally between -30 degrees and -90 degrees. And then the right axis deviation is usually between +90 and +180. All right, so now there are some certain pathologies associated with left axis deviation and right axis deviation. Let's go through some of those. Let's say you had an ECG with a positive deflection of the QRS complex on AVL, which could be normal or maybe even abnormal as well. But there's also a positive deflection of the QRS complex in AVR. So this is going to be a left axis deviation because that common area is likely going to fall somewhere between -30 and -90 degrees. Now, what causes left axis deviation? Well, things like inferior wall myocardial infarctions, left anterior fascicular blocks, left ventricular hypertrophy, sometimes, not always, or maybe even a left bundle branch block. So if a patient comes into the ER with chest pain and you see an ECG with left axis deviation, what might that indicate? Well, that's pretty concerning for an inferior wall MI. So you're going to have to look further into that. So if you have a positive deflection of the QRS in limb lead 3 and AVR, that's likely going to be a right axis deviation. Now the common area is going to fall between positive 90 and positive 180. Now technically, you could see a negative AVR with right axis deviation between maybe 90 and 120 degrees, but you're most likely going to see it positive when that deviation is greater than positive 120. Now, the right axis deviation can be caused by a lot of things as well. By right ventricular hypertrophy, acute right heart strains, like something that might happen like a massive PE might lead to that, a left posterior fascicular block, or a right bundle branch block. Now, having said all this, one very quick and easy trick to determine if the axis of the ECG is normal is actually just look at limb lead 1 and limb lead 2. And if the QRS is positive in both, then it's likely that the axis is going to be normal. So a positive deflection, limb lead 1 and 2 normal. But if you get a positive deflection in limb lead like AVR, it's almost always going to be abnormal because that vector is in the complete opposite direction of what is normal. So you can look at those 2 or even 3 and you'll get a good idea there. All right, let's see if we can hit this again in a different way in a Lewis Notes. Okay, so in this Lewis Notes, we're looking at our axis deviations. And instead of giving you a bunch of EKGs and asking you, well, is this left or right, we're going to go backwards. We're actually going to tell you that it's a left axis deviation or a right axis deviation. And then we're going to actually put in if we think there's going to be a positive or a negative deflection on the EKG. Now, for a cheater, I actually put the actually mean axis over here so we can actually practice and look at the 1, the 2, the 3, the AVF, the AVL, the AVR. All right, so first we have the left axis deviation. So we look at our left axis deviation area, and we're looking at this area over here. So this is the kind of the area that we're going to be looking at mostly for our left axis deviation. So keep that in mind when we're thinking about is this going to be a positive or negative deflection. So first we have in our limb lead 1, what are we going to see in 1? Well, more than likely if we're going to try to hit that area over there, we're going to see a positive deflection here. So we're going to see a big positive deflection, maybe nothing going on there. And I'm not going to make these really pretty EKGs just for speed's sake. And then if we look at 2, well in 2, it's likely going to have to be a negative deflection because you see it's basically in the opposite direction of 2. So we're going to see a pretty big dip right there, and it's going to go across. What about 3? Again, 3, it's basically going in the exact opposite direction. So you're going to see a really big dip of a negative deflection in 3. What about AVR? AVR maybe might be a little positive, but it's maybe a little neutral as well. So sometimes in AVR you'll see kind of this kind of medium looking one, but it's not going to be negative, that's for sure. And then in AVL is going to be about where we want it to be in the right direction. So that's going to definitely be a positive deflection on that one. And then in AVF, again, it's kind of going in the opposite direction. AVF is going down for the floor. That left deviation, axis deviation, is pretty much at the top. So we're going to see another pretty big deep dip right there. All right, so let's move over to our right axis deviation. So if we're looking at the right axis deviation, we're looking like more in sort of this area over here. Somewhere over here is about where we want our right axis deviation. So that's where we're going to go from there. So in 1, what are we going to see here? Well, 1, it's basically going to be almost in the opposite direction, so we're definitely going to see a negative deflection here on 1. On 2, it could be a positive because you are seeing that over there, so you might see maybe a medium or kind of a neutral looking thing, but I think you're going to see more of a positive on this one. On 3, definitely you're going to see a positive because it is going in mostly the right direction from there in regards to that. AVR might be a little neutral. Again, remember we talked about AVR being a bit neutral in that last one, but in this one we're probably going to see a little bit of a back and forth here. AVL, big negative deflection here, so that's what you're going to see there. And then in AVF, we are going down in that right direction, so that's going to definitely see us with a positive deflection there. All right, so really not all that complicated, but if you really need to keep the big axis deviation chart in your mind on where 1, 2, 3, AVF, AVR, and AVR are going to be, and that way you won't get fooled. Okay, so when you're looking at an ECG, there are tiny little boxes all over the place, and for every 5 boxes, you're going to see one of these big bolded boxes. Now, each tiny little box is 1 millimeter, and each 1 millimeter segment is going to represent 0.04 seconds, so not much time. And then for every 5 boxes, you have that bolded box, and that's going to be 5 millimeters, and then you just multiply it out. It's 0.2 seconds, or 200 milliseconds. So let's look at a normal ECG here. What is the first bump in the tracing? Remember, that's going to be your P wave. And the P wave is going to represent atrial depolarization. Now the signal is starting in the SA node, and then it's going to travel through the atria and then get to the AV node. Now after the P wave, we get to the QRS complex. But before we talk about that, we need to talk about the PR interval. So what is the PR interval? Well, it measures from the beginning of the P wave to the beginning of the QRS segment. Now it's actually stopping at the Q, not at the R. That can be a little bit confusing, I know. Now the PR interval is a measurement of the conduction delay through the AV node. Now normally, the PR interval is less than 200 milliseconds. So if you see a PR interval that is longer than one giant bold box, then that is going to be a prolonged PR interval, which can then indicate maybe something like a heart block, and we're going to talk about that in detail later. Now the QRS complex is a ventricular depolarization, which is how long it takes for the signal to get from the top of the ventricle to the bottom. Now you'll notice that the amplitude of the QRS is much larger than the P wave, and that's because the ventricles have a much larger mass of muscle. Now normally your ventricles are depolarizing at the same time. The electrical signal goes through the Purkinje system and the bundle of His, and you have equal depolarization of both ventricles. Now the reason why the QRS complex is very narrow and less than 120 milliseconds is because you are depolarizing the ventricles again at the same time. So how many boxes is 120 milliseconds? Remember, that's just 3 small boxes. Your QRS complex should be within 3 small boxes. Well, let's just say that you don't go through that Purkinje system, the bundle of His, and you depolarize maybe the right ventricle first, and then finally it's going to depolarize the left ventricle next. And that's going to take a lot longer and will result in what we call a widened QRS complex. This could be a ventricular rhythm, meaning that the signal is not originating from the AV node, but rather somewhere else in the ventricle. Now the normal very fast signal through that heart starts again from that SA node. It's going to travel down the AV node, and then the signal speeds down the bundle of His and the Purkinje system. Now if that signal starts or travels in a wrong direction, then you usually get an abnormal and probably a widened QRS. Now the T wave is what's going to represent ventricular repolarization. So this is the recovery of the ventricle so that they can then be depolarized again. Now the ST segment connects the QRS complex and the T wave. The ST segment represents the period when the ventricles are depolarized. And as many of you already know, when we talk about myocardial infarctions, we look in this area for any elevation or depression. We'll talk again about that later. Also, T-wave inversion may indicate a recent MI. And those T-waves, again, can also be affected by potassium levels. So if you see peaked T-waves, that might, again, indicate high potassium levels. And then again, flattened T-waves might indicate very low potassium. And then there's another wave called the U wave, and that's thought to be the repolarization of the papillary muscles or the Purkinje fibers. So these are often not seen and only sometimes appear after the T wave. Now, prominent U waves may be associated with hypokalemia or hypercalcemia, and then maybe even hyperthyroidism. Now, the speed of conduction goes very fast through the Purkinje system and a little bit slower through the atria, pretty slow through the ventricles, and very slow through the AV node. Now the SA node is obviously your pacemaker, but what if your SA node is not functional? Then your AV node is going to end up taking control. If your SA and AV nodes aren't functional, then the bundle of His and the Purkinje system will potentially take control. And again, if the SA node and the AV node and the bundle of His and all those Purkinje systems are providing the electrical signal, then you're going to get this really nice narrow QRS. If all of these are non-functional and then the ventricles have to start doing this, then potentially you're going to get these really wide QRSs. It's going to be longer than that 120 milliseconds, longer than your 3 boxes. So that's a good thing to know, that where is the originating signal coming from. If it's from the top of the heart and if it's going through the regular conduction system, it's going to be really skinny QRS. But if it's coming from the bottom of the heart or from the ventricles or something else is going wrong, then you're going to get a really wide QRS. All right, it's time for that end of session quiz. Let's go through those answers together. First question, how does the cause of a narrow QRS complex differ from the cause of a wide QRS complex? So a narrow QRS complex indicates that a beat is conducted through the normal conduction pathway. So it's either a sinus beat or an ectopic atrial beat, or maybe even supraventricular tachycardia, or even a junctional rhythm. But if the QRS is narrow, you know that the depolarization is coming through the AV node and down the Purkinje system. Now with a wide QRS complex, the depolarization is not being propagated normally by that conduction system. Either you have a beat originating in the ventricles themselves, like a PVC, or maybe a ventricular tachycardia, or maybe you have some conduction system disease like a bundle branch block, so it takes longer than normal for the ventricles to actually depolarize. Next question. What is the ECG axis given the QRS deflections in the following scenarios? So let's put on our thinking caps here. Positive in lead 1, positive in lead 2. That's easy. Remember, that was the trick. If those two are normal, normal axis. Positive in lead 1, negative in lead 3. That's probably going to be left axis deviation. Next, we have negative in lead 1, positive in lead 3. That's probably going to mean right axis deviation. And then we have positive in lead 1, negative in AVR. That's still going to be another normal axis. Next question. How does hyperkalemia affect the shape of T waves? So remember, T waves mirror the potassium level. So with high potassium, you get tall peaked T waves. With low potassium, you get flattening of the T waves, maybe also a U wave. Next question. What are the most common causes of left axis and right axis deviation? So remember, left axis deviation, you got to think about inferior wall myocardial infarction, left anterior fascicular block, left ventricular hypertrophy, and left bundle branch block. For right axis deviation, you got to think about right ventricular hypertrophy, acute right heart strain like a massive PE, left posterior fascicular block, and then maybe a right bundle branch block. All right, guys, that brings us to the end of session quiz and the end of the video. I hope you learned something. I'll see you next time.